I want to welcome everybody to this week's happy hour session. As is always the case, if you have any questions at all, I've got to open up my chat actually, by the way. Let me get it up here. You can just put your questions into the chat and I'll try to look at it from time to time, or definitely at the end of the session. Alternatively, April just put that up. You can always email us at education@sagisdx.com, or you can email me directly, tdavis@sagisdx.com. Certainly don't mind you calling me either or texting. My cell phone is 210-416-4815. So today, what I thought we'd do is just something a little different. What I thought I would do is go over this year's most commonly queried differentials. And to that end, obviously, we're going to be focusing on histological lookalikes. And anytime you study lookalikes, it involves a consideration not only of how things are different, but how they're similar. So we're going to spend a little bit of time with each of the entities looking at both similarities and differences. And basically, some of these principles we're going to be applying to the following differentials. We'll discuss dermal duct tumor versus nodular hidradenoma, deep penetrating nevus versus cellular blue nevus, Chromoblastomycosis versus Phaeohyphomycotic cysts, fixed drug eruption versus Erythema multiforme, Glomeruloid hemangioma versus tufted angioma, and elastosis perforans serpiginosa, EPS, elastosis perforans serpiginosa versus reactive perforating collagenosis. So let's go ahead and get started. And I'm going to go ahead and flip the slides from time to time. And our first differential consideration is between a dermal duct tumor over here on the left side of the screen and a nodular hidradenoma over here on the right. And both of these come from the same family of eccrine adnexal tumors. Specifically, they're acrosyringeal tumors. They belong to the acrospiroma family, and they show differentiation towards the acrosyringium, which of course is the intraepidermal portion of the eccrine duct. Both of them, because they are epithelial tumors, are composed of tumor islands, and the cells making up the tumor islands, both here in our dermal duct tumor and here in the nodular hidradenoma, tend to be very uniform cuboidal cells with pink cytoplasm. And in both instances, because they are eccrine ductal tumors, the tumor islands are going to contain some eccrine ducts, which are usually cuticle lined, and some of the ducts, of course, will contain sweat. So that's kind of how the two are similar. Well, let's go ahead and look at each one of them individually and kind of discuss the differences. First of all, before we do that, I think one difference we can appreciate right at scan is on the left, we have the dermal duct tumor. And you can see the architecture of this tumor is such that it's composed of multiple small dermal nodules without an epidermal connection, okay? If we look at our nodular hidradenoma, and hydradenomas in general, they typically are a single large dermal nodule or one or two dermal nodules, and they frequently will have an epidermal connection. Now, the epidermal connection, which we don't see in the dermal duct tumor, but we do see in the hidradenoma, can be quite small. And these, of course, are three-dimensional tumors. So if you happen to get a section cut near the edge of the tumor, you may not see that epidermal connection, but typically they do show attachment to the overlying epidermis. So that's a difference between the two of them that I think is best appreciated at low power. Let's go on down and take a look at the cells comprising our dermal duct tumor. And as we move to higher power and start looking at the constituent cells, we can see that these are very, very monotonous, very bland. They have uniform round to oval nuclei, a moderate amount of pink staining cytoplasm, and they're very homogeneous. This dermal duct tumor, of course, is a member of the peroma group of tumors. The peromas and the hydradenomas are the two big subsets of our eccrine acrosporoma group. So we've got eccrine acrosporomas that show differentiation towards the intraepidermal portion of the eccrine duct. And in that group of tumors, we have poroid tumors. The dermal duct tumor is one of those, and our hydradenomas. Now, what are the other family members of a dermal duct tumor? Well, if we had tumor islands with this same makeup, in which there was attachment to the overlying epidermis and extension into the dermis, we would call it a peroma. If, on the other hand, we had these neoplastic aggregates, these poroid cells confined to the epidermis, we call it hydroacanthoma simplex. And then finally, if they're confined to the dermis, we call it a dermal duct tumor. And because of the monotony of the cellular population, jokingly, we refer to these tumors as boromas because they've got extremely boring cytologic features, okay? So let's go on over and see how the nodular hydradenoma differs. Well, if we go down and take a look at the cells here, we can see that unlike our typical peroma, the cells of a nodular hydradenoma, while they are uniform, show a tendency to accumulate glycogen in their cytoplasm. They tend to undergo, as a result, clear cell change. And because of the clear cell change, they tend to be a little more variable in size than typical cells of the peroma, which generally don't show much, if any, clear cell change. Occasionally, one can see a nodular hydradenoma or a hydradenoma, which is composed almost entirely of very clear staining epithelial cells. And you'll sometimes see that tumor referred to as a clear cell hydradenoma, okay? Sometimes within a hydradenoma, rather than having a solid nodule of cells like we have here, one will see areas of large cystic degeneration. And in that case, the hydradenoma may be referred to as a solid cystic hydradenoma. And it's important to recognize these names. They're just descriptive, because when you're taking an examination, certification exam or otherwise, or reading a path report, people will use kind of different names for the same body of tumors, and most of them are just descriptive. Now, my disclaimer with this particular differential, and it's kind of a principle that holds for really any of these conditions, is that as with all things in life, nothing is absolute. These lesions run along a continuum. The acrosporoma family. And so overlapping features are somewhat common. So what do I mean by that? Well, rarely, and don't put too much emphasis on this, but rarely one can see a nodular hydradenoma that's composed almost entirely of poroid cells. And sometimes people will refer to that as a poroid hydradenoma. On the other hand, very rarely within a dermal duct tumor or a peroma, one can see clusters of clear staining cells that more closely resemble those seen in a hydradenoma. So again, what I tried to do was pick out two tumors from you at total opposite ends of the spectrum. And on a board exam, there won't be a tumor with overlapping features. Your poroid tumors will look like this, very monotonous. The hydradenomas should have a number of clear cells in them. Again, just to summarize, the poroma on the left, multiple small dermal nodules, no epidermal connection, and very bland cytology. The hydradenoma on the right, typically a single dermal nodule or one or two larger dermal nodules, typically have an epidermal connection, and the cells do show a tendency to accumulate glycogen in their cytoplasm. Okay, And this is probably more than you ever wanted to hear about these two adnexal tumors. Okay, let's go ahead and move on to slide number 6. Slide number 6, we're going to be comparing on the left here, much smaller biopsy, a deep penetrating nevus with, on the right, a cellular blue nevus. So how are the two similar? Well, I think you can see even on scan, both are characterized by kind of bulbous cellular and expansile aggregates of pigmented melanocytes, which can extend into the deep dermis and sometimes even, as we can see in the cellular blue nevus on the right, into the underlying subcutaneous tissue. And they both may show a tendency to grow along neurovascular bundles. So, first blush, they appear quite similar. We're going to kind of look at this cellular blue nevus first. This is a much bigger biopsy. Let me flip the slide here. And the thing that you need to remember about blue nevi is that they are intradermal lesions. In a blue nevus, you will not have a junctional component. So the melanocytes are going to be confined to the dermis. Clinically, these are fairly distinctive lesions. As I'm sure most of you are aware, they tend to be a little bit larger, usually 1 to 2 centimeters in size, sometimes larger. They're usually bluish plaques or nodules. They do show a predilection for the buttocks, for the sacral area, and oftentimes for the scalp of young to middle-aged adults. They are, again, confined to the dermis, but typically a cellular blue nevus, as this one, will kind of fill the reticular dermis, often with deep extension of these bulging nodules into the subcutaneous tissue. And these bulging nodules frequently have a dumbbell configuration, but in a cellular blue nevus, they're always going to be sharply marginated at the base. So you can have these big dumbbell configurations, but again, they won't typically infiltrate into the fat. They tend to be sharply marginated. They also tend to be fairly symmetric tumors. And you can see there's a fair amount of symmetry here. One half of the tumor looks like the other. Another characteristic feature of cellular blue nevi is this tendency for them to have a biphasic makeup. And so if you take a look at this tumor, you can see that there are large, lighter staining areas within the tumor, and then somewhat more pink, darker staining areas out at the periphery. And these lighter staining nodules can be, I'm going to remove my pencil mark here, can be a useful clue to the diagnosis of a cellular blue nevus. And if we look at these centrally located lighter areas, we'll move in to higher power. You can see that these are composed of really tightly packed cells. They are relatively amelanotic. They're uniform. They have spindle to fusiform shaped nuclei and an even chromatin pattern. Within the surrounding stroma, there are melanophages. But what's characteristic of a cellular blue nevus is surrounding these lighter staining areas, there are zones of fibrosis, which we can see out here, containing melanophages and pigmented dendritic cells and spindled melanocytes. So again, this biphasic pattern is very characteristic. Centrally located, kind of more cellular, packed, lighter staining areas, and these are embedded in a fibrotic periphery containing melanophages, dendritic melanocytes, and spindled melanocytes, which tend to be very heavily pigmented. In a cellular blue nevus, there are typically few, if any, mitotic figures evident. So, if you start seeing a lot of mitotic figures near the base, you need to be more concerned about melanoma, especially if there's necrosis there. Well, what about the deep penetrating nevus by comparison? I'm going to go ahead and flip the slide here. Okay. Okay, let's go ahead and zoom in here. And let me tilt it a little more. Clinically, deep penetrating nevi have a different presentation as well. Whereas the cellular blue nevi tend to be large. Most deep penetrating nevi, rather than being 1 to 2 centimeters, are usually 6 millimeters and less or size. They tend to occur commonly, as do cellular blue nevi, in children and young adults. And they present usually as a dark black, brown, or bluish black papule. But there's no particular anatomic area of predilection, like cellular blue nevi. The other characteristic features that we tend to see with a deep penetrating nevus, this silhouette is very characteristic. And by that, I'm referring to the fact that the deep penetrating nevus, and my pencil is over here on the right, tend to have this inverted triangular configuration. They're kind of V-shaped, if you will, and they're typically very symmetric. The other thing that you need to remember about deep penetrating nevi, you'll remember we said cellular blue nevi are intradermal. Well, not infrequently, a deep penetrating nevus will be compound. It will have a junctional component. And here you can see we've got nest of melanocytes along the dermal epidermal junction. And again, you're not going to see that in a blue nevus. Now let's just back out a little bit and look at the architecture. And if you look at the way the melanocytes comprising this lesion are distributed in the dermis, what we have is these fascicles of melanocytes, and they're kind of intertweaved, producing a little bit of a plexiform growth pattern. And if we go down and look at the cytology of the melanocytes comprising a deep penetrating nevus, what we see is that the melanocytes are a little variable in size. So a deep penetrating nevus has a little more nuclear pleomorphism than your typical nevus. Most of the melanocytes tend to have oval nuclei. Some are a little more spindled, some can be fusiform, and some of the cells can have round nuclei and abundant cytoplasm. That is, they can have a little bit of an epithelioid appearance. Most cells comprising of blue nevi are lightly dusted with melanin pigment. So if you were to look under higher power, you could see very faint melanin pigment within their cytoplasm. And then between the cells in the dermis, one can see some melanophages. However, what's notably absent in a deep penetrating nevus, which was so characteristic of our cellular blue nevus, is the surrounding fibrosis. So we've got these cellular fascicles of cells. They're embedded in the dermis, but they are not surrounded by the fibrotic stroma containing dendritic melanocytes and melanophages that was so characteristic of the cellular blue nevus. One may see a few scattered mitotic figures as well. In a deep penetrating nevus, they should be normal in appearance. Now before we summarize, just a few comments that I wanted to make about blue nevi, because I think the whole area can be a little bit confusing. Really, the distinction of a common blue nevus from a cellular blue nevus is kind of an oversimplification of the morphologic heterogeneity that exists with blue nevi. You know, there certainly are a range of changes in blue nevi, with our classic common blue nevus, also referred to as a dendritic sclerotic blue nevus, and the typical cellular blue nevus, like the one we just looked at, also known as a spindled and fascicular blue nevus. Those are kind of rare poles of the spectrum. Blue nevi, much like we saw with the dermal duct tumor and the nodular hidradenoma, or like we see with cylindroma and spiroadenoma, they're not homogeneous in their cytologic elements. So in a blue nevus, the number and density of dendritic melanocytes, the number of melanophages, the degree of fibrosis and sclerosis in the stroma, and even the relative number of spindled, fusiform, and epithelioid melanocytes varies from lesion to lesion. So these things run along a spectrum. As a rule, however, the more the cellularity of a blue nevus increases, the more pronounced the nodular silhouette of the tumor becomes. So before moving on to our next case, just to summarize, cellular blue nevus and deep penetrating nevus, the clinical presentations are different. Again, cellular blue nevi, larger, certain sites of predilection, deep penetrating nevi, smaller. Whereas deep penetrating nevi are sometimes compound, our blue nevi are entirely intradermal. And again, remember the DPN, the deep penetrating nevus, has no fibrosis around the fascicles of the melanocytes, whereas at the periphery of the more cellular, lighter areas of a cellular blue nevus, there are melanophages and pigmented melanocytes in a fibrotic stroma. So hopefully that will help you guys as you guys are working through this particular differential. Okay, those were the two longest, so I promise I'll be a little less wordy with the last couple. So our next differential, we're going to look at chromomycosis on the left versus Phaeohyphomycotic cyst on the right. How are they alike? Well, certainly both are caused by implantation of dematiaceous or pigmented fungal or mold elements into the skin. And they both produce suppurative and granulomatous inflammation within the skin. And as a result, clinically, they both tend to occur at sites prone to trauma, particularly the distal extremities. I'm going to go ahead and start with chromo, and I'm going to flip it. I think people are used to looking at slides that way with the epidermis on top. And what we have here is a very characteristic appearance for chromomycosis. We've got marked pseudoepitheliomatous hyperplasia. You can see these tongues of very highly squamatized epithelium or epidermis extending out into the dermis. There's interconnection of these. There's not too much cytologic atypia. And in particular, we have pseudoepitheliomatous hyperplasia with pus. So we have small neutrophilic microabscesses present within the epidermis as well. A few up here, a little bit of scale crust on the surface. And this correlates with what one sees clinically. I mean, given this histology, it's not surprising that the patients usually present with verrucous papules or plaques. The causative organisms in chromomycosis are known as medlar bodies, there's some right here, or copper pennies or sclerotic bodies. They tend to be located, as is the case with most fungal infections, either within microabscesses, sometimes within the cytoplasm of multinucleated giant cells. And the thing to keep in mind is these sclerotic bodies or medlar bodies are spores. Now, there may be internal septation in these, but the one thing you will not see is branching septate hyphoelements. And that's really what distinguishes a Phaeohyphomycotic cyst from chromomycosis. So let's go ahead and move over and take a look at our Phaeohyphomycotic cyst by comparison. Bear with me, I'm going to flip the slide. And in this particular biopsy specimen, you can see that the infiltrate is present deeper in the dermis. And typically we see nodular collections of histiocytes and neutrophils deeper in the dermis or subcutaneous tissue surrounded by fibrosis. And of course, clinically, the patients tend to present with deep dermal or subcutaneous nodules. This histology is very characteristic. And as we move in, you can see that we've got this large central abscess, a lot of newts and neutrophilic nuclear dust. This is somewhat of a stellate abscess here. You can see it's a little star-shaped. And then out at the periphery, it's kind of encased by a nodular collection of epithelioid histiocytes, some of which are multinucleated. And then when we look here in the tissue, we begin to see pigmented septate hyphoelements, which in some of the sections were branching. And this is a distinct morphology that is different from the spores that we saw with chromomycosis, okay? So generally, just keep in mind that in distinguishing Phaeohyphomycotic cyst from chromomycosis, the clinical presentation, the host response, and the morphology of the organisms is going to be different, but they both are caused by pigmented fungal elements. Okay, let's go ahead and move on to our next differential. We're going to consider fixed drug eruption on the left versus erythema multiforme on the right. And I think, especially when you're first starting out in Dermpath, I mean, inflammatory dermatopathology is kind of hard to begin with because there is a lot of overlap in conditions despite clinically being different. The interface dermatitis are a lot more alike in many instances than they are different. And that's obviously what is the similarity between these two conditions. They're both interface dermatitis, fixed drug eruption and EM. They're both characterized by vacuolar change along the DEJ. Okay, they both are characterized by necrotic keratinocytes within the epidermis, and they both can demonstrate varying amounts of spongiosis and ballooning of the epidermis, even leading to intra and subepidermal blister formation, depending upon the age of the lesion. Well, how can we tell them apart then? Well, let's go ahead and look at our fixed drug eruption here on the left. And this one's even a little more confounding because it's got a basket weave cornified layer. Sometimes in a fixed drug, you will see a basket weave cornified layer. It's not unusual, however, to see some parakeratosis or scale crust in a fixed drug eruption. The epidermis is mildly hyperplastic. I think, as we move down, you can see there's fairly pronounced vacuolar change along the dermal epidermal junction. Within the epidermis, there are scattered necrotic or dyskeratotic cells. This is skin of color. There's an increased amount of melanin pigment within basilar keratinocytes. And to that end, not surprisingly, within the underlying papillary dermis, they're not only lymphocytes, there are melanophages. And if you have an interface dermatitis on skin of color, don't automatically assume if you see melanophages in the underlying dermis that it is a fixed drug eruption, because any interface dermatitis in skin of color, be it EM, be it Mucke-Habermann disease, be it lupus, if there is pronounced vacuolar change, you're going to see melanophages in the dermis. So they're not pathognomonic or specific for a fixed drug eruption. What is, however, is the presence of eosinophils within the infiltrate. And as you move along the DEJ here, if you looked at the sections, there were not only lymphocytes and melanophages, there were rare neutrophils, and then you can start seeing these bilobed eosinophils here. The sections were a little thick, but I think these were clearly identifiable as eosinophils. And when you start seeing those in number, you need to think about a fixed drug eruption. Well, how does that compare with erythema multiforme? And I'm going to go over, flip the slide here. Here we've got a bisected punch biopsy. This is a much more pale slide, but one of the histologic hallmarks of erythema multiforme is a basket weave cornified layer. So if you see an interface dermatitis with a basket weave cornified layer, EM, is always in the differential diagnosis. In late EM, one can occasionally see a little bit of parakeratosis, but usually by that point, the epidermis is almost completely necrotic. Okay, let's go ahead and look along the dermal epidermal junction here. If we move to higher power, move this down a little bit. We can see some vacuolar change along the DEJ. We see scattered necrotic keratinocytes in the epidermis. And within the underlying dermis, we see lymphocytes and several melanophages. And again, this is skin of color, so it shouldn't be a surprise that we're seeing melanophages here. So don't automatically assume this is a fixed drug eruption, because if you go and take a look at the infiltrate, it's lymphocytic only. There are really no eosinophils within the infiltrate. So erythema multiforme. So again, distinguishing these two, there's a lot of histologic overlap. Again, they both have vacuolar change. They both can have a vascular weave cornified layer. They both have necrotic keratinocytes within the epidermis, but within the dermis, in erythema multiforme, we see a superficial perivascular infiltrate of lymphocytes, and with fixed drug eruption, the infiltrate is going to be mixed, containing lymphocytes, frequently eosinophils, neutrophils, and melanophages as well. So hopefully that will help you out there. Okay, coming into the home stretch here, the next differential that we're going to discuss, and let me back out a little bit. I think these were widely scattered on the slide here. We have a glomeruloid hemangioma on the left versus a tufted angioma on the right. And this can be somewhat of a difficult differential because, if you look at these on scan, they're both characterized by lobules or tufts of capillaries kind of scattered throughout the dermis. So at first blush, they look very similar. A glomeruloid hemangioma, as we'll see in just a minute, has kind of distinctive features, though, that will help distinguish it. So if we go down and take a look at our glomeruloid hemangioma, we can see that we have these collections of capillaries, these capillary loops in the dermis, but they resemble glomeruli. You have to go back to medical school and remember what a kidney looked like. They resemble a glomerulus in that they're located within a dilated vascular space. So you can see this is plopped down in the center of a dilated vascular space. And at the periphery, these vascular spaces at the periphery of these capillary loops are somewhat crescenteric in shape. Not only that, if we go in and take a look at the capillary loops, a very characteristic feature of a glomeruloid hemangioma is their tendency to sequester degenerating RBCs. So you can see these RBCs are not real bright red, they're a little pink, and some of them are fragmented. So if you see sequestration of degenerating erythrocytes in a tumor that has these capillary loops, you need to think about the possibility of a glomeruloid hemangioma. Let's take a look at another one of these loops, and I'll show you as well the sequestered degenerated RBCs. You can see they're present in almost all of these capillary loops. Go back and take a look, and I think you'll see them. And of course, glomeruloid hemangiomas are seen in patients with Poems and Castleman's. So I would be familiar with the clinical setting and the characteristics of those conditions, because I think this would be a real good slide to show on the applied examination, because you could ask a lot of questions about it. Okay. Let's go ahead and move on over to our tufted angioma. These are also known as angioblastomas. Let me flip the slide. And what we see here are just these large capillary tufts. People have likened them to cannonballs, just throughout the dermis here. And there may be a few crescenteric vessels kind of at the periphery, but these capillary loops are not sitting in a vessel. And if you go in and look at the loops, you'll notice that there's no sequestration of degenerating erythrocytes in a tufted angioma. And of course, the clinical presentation is different. Tufted angiomas usually present as kind of ill-defined, slowly expanding plaques on the shoulder is a common area of children. And they may be associated, of course, with Castleman-Merritt syndrome. One other thing that you might consider here in the differential would be an intradermal pyogenic granuloma. There are pyogenic granulomas that occur deeper in the dermis, and they are characterized by these capillary collections of capillaries, but they're separated by fibrous septae that contain ropey collagen. They're never this widely scattered, so you'll see the septae separating the individual capillary lobules. Okay. Our last case, we're going to look at a couple of disorders that both are characterized by perforation. We have elastosis perforans serpiginosa on the right, and reactive, I mean on the left, and reactive perforating collagenosis here on the right. And what's characteristic about EPS, well, there are a couple things that are characteristic. For one thing, the transepidermal elimination channel in elastosis perforans serpiginosa is typically more narrow and tortuous, and it tends to course through, as you can see here, a hyperplastic epidermis. Frequently, one will see little pinchers at the base of the channel. These kind of look like vacuum cleaners. And you can see within these channels, what you have is a marked increase in the number of these kind of large, bulky red elastic fibers. And this is a very characteristic appearance of EPS. So bulky red elastic fibers, number one. Number two, they're increased in number. And number three, the transepidermal elimination channel is going to be more narrow, tortuous, and course through a hyperplastic epidermis. Of course, this leads clinically to the accumulation of papules, which tend to coalesce either into an arsiform or serpiginous plaque. The lesions tend to show predilection for the neck. Sometimes you'll see them on the face and on the upper extremities as well. And of course, it can be associated with a number of other conditions, and make sure you know all of those conditions so you can see EPS and its kind of definite favorite board fodder. Let's go ahead and compare this to RPC. Well, I think you can see right away, and let me tilt the slide here, that the transepidermal elimination channel and RBC is entirely different. It's just really a broad dermal channel rather than that narrow, tortuous channel coursing through the epidermis. Frequently, one sees a centrally located ulceration. And rather than seeing transepidermal elimination of these bulky, brightly eosinophilic elastic fibers that are increased in number, what one sees is vertically oriented collagen bundles that are being extruded, usually from the surface of the ulceration. These are bigger, they're more variable in size than the elastic fibers, and frequently, because there are a lot of neutrophils present in the setting of RBC, the collagen fibers will start taking on a bluish color. So they're more common like blue actually than the red fibers that one sees in elastosis perforans serpiginosa. And of course, clinically, the patients present with papules or nodules with a central embellication. RBC, of course, can be inherited in an autosomal dominant fashion. In that instance, usually it occurs in younger individuals, earlier onset sites of trauma. In the acquired form, which is more common, we tend to see it in the setting of chronic renal failure and or diabetes. So that's about all I have, kind of a whirlwind tour of histological lookalikes. Again, if you have any questions, please let me know. Please feel free to call or email Sagis or me directly. And certainly always open to any suggestions that you guys have for these happy hours. Next week, Dr. Fisher, who is one of the derm-trained Dermpath dermatopathologists, Sagis Diagnostics, will be discussing a number of very interesting inflammatory diseases. So hope you guys have a great evening. Thank you.